Welcome, everyone, to the Humanitarian Heartbeat podcast. I am your host, Nia Imani, and I have the pleasure of interviewing such a beautiful person inside and out, my friend, the model, the CEO, the advocate, Jamil Rivers.
Thank you for having me.
Of course, thank you for joining us.
Congratulations.
Thank you. I appreciate it. Everyone is going to know. I mean, I'm sure everybody has known you and know your face at the very least because you're all over the news, catalogs. What we're just talking about, People magazine. Where else have you been? I mean, Oprah show. I mean,
All over the place, wherever I can, be an advocate and, make people aware of what's going on with Black women when it comes to breast cancer and share my experience and my story. I'm going to be there.
your bio so everybody can know in particular why you're so. I mean, you're always important. People are important, but disparities in care for these women. As a survivor herself of metastatic breast cancer, she advances navigation and coaching for patients like herself in order to overcome the bias that leads to life endangering inequities in treatment. Her organization, the Chrysalis Initiative, collaborates with cancer centers as a foremost voice for proper standards for care for all patients, regardless of race.
Yes.
Now, you got me, you're gonna have me have answered ask the questions all over, okay? Because the first question automatically, why specifically Black breast cancer?
Well, it is a bit self-serving because I am a Black woman, and when I was diagnosed, my son was in kindergarten, and I saw that Dr. Google said that the median survival of metastatic breast cancer was 3 years, and that Black women are um, have a 42% higher rate of death than their white counterparts, and also a 71% um, higher rate of death than have 71% more likelihood to die from metastatic breast cancer. And I just learned recently um, at the AACR conference that 95% of Black women, they represent um, 95% of the advanced deaths in breast cancer. And so, the inequities are there. And so when I was diagnosed, I was told that it was due to Black women being non-compliant or, being poor, not having suitable insurance. But the Black women that I was connected to, all of them had good jobs. They had good insurance. And as they were sharing their stories with me, we found that the barrier to them receiving quality standard of care was the health system itself. So why is that? And so that's really where the Chrysalis Initiative was born. I had, set out to seek what is, learning about breast cancer. What is it that I have? Who knew that it was complicated? Learning about making sure that I had all the right resources to kind of give myself a shot, to be here for my kids. And then from, just putting one foot in front of the other, going to work every day because I worked through chemo. Other women started popping into my chemo room of all races. But what was interesting about the Black women is that there were all these little um, holes in what they were supposed to receive. And so it was just like a car going down the street. If you poke the tire and just constantly poke holes in it, it's going to crash. And so these women, their standard of care was Swiss cheese. It was missing key elements to make sure that they should receive the quality standard of care. And so I always hear, from the researchers and the healthcare providers and even nationally in the government that it's a access issue, right? But I don't think it's an access issue. I think it's a access to quality issue. So you can't just say, okay, we have this great health system, we have all these great resources, we have all these great doctors, we have all this coverage and insurance. But if a patient is not receiving what they're supposed to receive and the care they deserve, then they're not going to have good outcomes. And so that's where the Chrysalis Initiative was born. And I thought, how could we set ourselves apart in the current landscape? My experience being diagnosed, connecting to all those advocacy organizations is everything was dumped on the patient. And I'm like, okay, if I go to the dentist, right, and I need a root canal, I shouldn't have to have a dental degree to figure out, okay, let me make sure you're giving me the root canal I'm supposed to get, right? And so, why is it that we have women now have to have PhDs in oncology to fact check their doctors and make sure they're receiving what they're supposed to get? I mean, unbeknownst to them, they're supposed to have all, really have all this stuff on them to ensure that they get the care they need. I just thought that was unacceptable, meaning it should be standard of care, meaning if I have breast cancer, make sure that you give me the appropriate testing to determine what I'm working with and then give me the appropriate care accordingly.
So, why aren't Black women receiving equitable care? What?
So I believe it's a lack of accountability. It's just so easy for either breakdowns within the care system, and also implicit and explicit bias, where I actually compare Black women going into the health system as similar to a Black man being pulled over by the police. That is that is how vulnerable Black women are going into these spaces where a lot of times, we're still a very segregated country. Only 2% of oncologists are Black. And so if you think about going into these spaces where there's still this gulf, you're going to have a breakdown in patient clinician communication if those biases are prevalent. And a lot of times we're just not registering as being humans for these folks to care about or to prioritize. There's just biases that come into play here. And with the lack of accountability, where someone has the autonomy to give me substandard care, who's going to check me, So, and unbeknownst to the patient, they don't know that they're receiving substandard care, right? So, how can we make sure that we have the equalizer? So, the Chrysalis Initiative, we assess whether or not if you are receiving standard of care. You also have the breast cancer guide that's has a glossary and all of that within BC Navi, which is our app. And you're connected to our wraparound services team, and you're connected to a coach who's a survivor and a thriver who has a similar lifestyle, similar experience to you that you can connect in all these different ways because it's overwhelming. So, again, why is it that we're putting all this pressure on the patient to figure out what they're supposed to receive? It should be standard. But right now, there is that lack of accountability, and these biases are coming into play. But I do believe, and sometimes there are issues where it is an insurance or income issue. But guess what? Most of the time, those barriers can be resolved. And so we find that if a Black woman, despite the barrier, if she receives standard of care, she's going to have comparable outcomes to her white counterparts.
Your research is phenomenal. Now, to the people who are going to listen to this and see this, and what if they say, "Well, why would the physician suggest or provide substandard care?" What's your response to that?
I mean, I really don't understand, actually. Don't. It's almost like, why do people commit crime, right? But I look at it like it's the healthcare system. We're dealing with people. People have biases that influence them in different ways. And I do believe that most of the hospitals, they have these resources and processes and systems in place because they want people to receive equitable care within their health system.
Mhm.
However, you have to hold the bad actors accountable.
Mhm.
And that bias can show up in a number of different ways. When you think about that continuum, again, that road of cancer care, right, with the car,
Mhm.
you can come up against so many different road bumps. And where are you going to reach that road bump? It could be in billing. It could be when you first present with symptoms. It could be when you're trying to get your mammogram or your diagnostic test scheduled. Or did you even get the complete diagnostic workup done? You know, are there some tests that are missing? Is it when you get to the nurse practitioner, or if you're having a scheduling issue, or is the parking or the copays a barrier? So it's a whole bunch of different areas where that barrier could pop up. But the thing is, there a lot of health systems are working in silos. When you do have a bad actor where they are coming up against someone who potentially does not provide them with the care that is needed. And I get that hospitals are stretched and, under resourced. I get that. But there definitely should be accountability. If you are a health system and you are operating in this country, I think that if you want that equity credit, you can't just have swaths of people in
Mm.
populations and just blame it on socioeconomic issues. Meaning you need to provide care and it needs to be the standard of care that is accepted as the national guidance.
That's awesome. That's awesome. You said get it right. In other
Mhm.
words, now let's go back. Tell us your story of being diagnosed with breast cancer because it's not an average story.
I was the typical busy executive, mom of three boys. And, we had just moved into a new house. And again, my youngest was in kindergarten. They're going to school. And of course, they bring home the germs, right? And so everybody caught their colds. But my cold came and it didn't go away. So I'm just a hacking and a coughing and a sneezing. I mean, I'm doing presentations at work and I needed a cup of hot tea just to get through a normal presentation. And so I went after a while, I'm using cold medicine, nothing changes. So I go to my primary doctor. I'm letting her know, hey, what's going on? And so she prescribes me an antibiotic and no change after 2 weeks. I go back, she prescribes me an asthma pump. 2 weeks of that, still no change. And so then I just asked, well, can I get like a chest scan to see what's going on? And I also felt like this little pinch, or it felt like a piece of hair that was stuck on my hip. Not painful, but it was like, what's this? I
Mm.
just felt something and felt absolutely fine, other than this cough and this little strand of hair that felt like it was on my skin. So I asked for an ultrasound and the chest scan. So got the chest scan and the ultrasound, and they said that you have a shadow in your lung and lesions in your liver. So I'm like, well, what would cause that?
I have a cold. Yes.
I was only 39 at the time, so I hadn't had a mammogram at that point and wasn't aware of any breast cancer in my family. But when they told me that, my brain went back to 2015. So I was diagnosed in 2018. Back in 2015, I had a miscarriage. So back in 2015, I had that miscarriage. And I remember when it did happen, my breasts kind of prepared for motherhood and engorged with breast milk and all of that. But when I had the miscarriage, only my left breast went absolutely back to normal. My right breast had some skin discoloration and some textural changes and felt firmer. And my OBGYN at the time said, well, she wasn't too concerned because that was my overactive breasts, right? Because I breastfed my boys and I breastfed them for a year each one. And so she was saying, you know what? I don't think you need to worry about it because that's your overactive breasts and you don't have any history of breast cancer in your family. But when I heard that I had lesions in my liver and a shadow in my lung, that's where my mind automatically went. So it was almost like
Yeah.
God said, get the mammogram. So I told them what had happened. I asked for the mammogram. They did the mammogram. They also did the biopsy and in additional CT scans and MRIs, and found that I had breast cancer that had already spread all over my body, except for my brain and my spine. And I was stage 4 de novo. So stage 4 from the start.
Say something to your OBGYN.
By that point. So yeah, I actually haven't spoken to that OBGYN since then. Yeah.
If you had not asked for a chest X-ray, an ultrasound, a mammogram, what mm, What does that say? Do you think if you had not have asked, they would have done it?
Oh, no, I think that because I had no known history, because I was under the age of 40, because I didn't have a lump, you know, um, I just missed all those, you know, flags for my primary doctor to even think of that.
So wild to me, Jamil, because you and I know that genetic cancer or breast cancer only make up a small percent.
Right. I know.
So while it's important and we're not
Right.
denouncing that, why is that sort of
Right.
the basis of the reason why you should get the
Right.
testing?
Exactly. Yeah. Hmm.
So okay, so we didn't talk to the gynecologist who we want to slap. We had to ask a million times, when you got that diagnosis, what were, if you can remember, because I'm sure it was a million, what were your thoughts?
Me with. I have these beautiful children. My youngest is in kindergarten. Why would God bless me with this beautiful family and then strip me from them? So that was immediately what I was thinking. I just said, well, is it terminal? Because they said stage 4. And the radiologist actually said, you know, um, I have a whole floor upstairs of women with metastatic breast cancer. And so you're not going to die tomorrow. You're not going to die next week. And we're just going to take it one step at a time. And so, of course, I was immediately devastated. I mean, I came home, had to tell my husband, that I had to call my family, my dad and my sister and my mom, and say, I have stage 4 breast cancer, you know? And, I'm supposed to be the healthy one because my husband was already a colon cancer survivor. And
Jamil.
so, who's going to take care of these babies, And so I just absolutely was devastated, crying, devastated. But again, Dr. Google said I had 3 years, right? And then I also saw that there were 2% that lived longer than that.
Mm.
So I said, well, somebody got to be in that 2%, right? So I have to give myself a shot. And so I started researching, what am I dealing with? And so luckily I was able to go to the National Comprehensive Cancer Network that has the kind of cheat sheets, if you will. This is breast cancer. This is what you're dealing with. How do I make sure that I'm getting the right care for myself? Researching clinical trials, researching how breast cancer behaves in Black women, researching which treatments actually work well in Black women. I also went and got a second opinion, with a different institution just to make sure that I'm covering all my bases here, making sure I'm getting all the tests that I need. And then I definitely reached out to all of the advocacy and support resources because, again, I didn't want my husband to then have a relapse of some sort because he's stressed out taking care of me. And so I just tapped into all those resources and just said, all right. And I actually didn't disclose to my job that I had breast cancer because I had just started that job 5 months prior. And so, of course, FMLA, in order to be eligible, is 12 months. And I always read, I remember watching 2020 and Dateline and them saying, what, that there's financial toxicity and
Yeah.
maybe 1 out of 12 or 12% of breast cancer patients have to file for bankruptcy. So I said,
Yeah.
well, I know I'm going to need insurance and I know I'm going to need income. So I ended up getting my eyebrows tattooed and put a wig on and went to work every day. And so just went to chemo and said, all right, I'm going to do this. And that's what I did, in order to just keep the family together.
So there's two questions. I mean, a million. How how did you have the mental capacity to not only go on Dr. Google, but to sift out what is the correct information? And then even in your, I guess, your grief, you still thought about your husband and, I don't want him to relapse. And you how what kind of mental what?
That's what Black women do. We figure it out, right? And I think of like my mom, where she had a kidney transplant and, well, needed a kidney transplant and was going through dialysis and still going to work. And I didn't understand it at the time, but now I do because, I'm a grown up, I'm a mom, I have kids to take care of. But I think that's just that fortitude. Even my grandmother. And it's a cautionary tale as well,
Yeah.
making sure that I make sure that I'm present and I have balance. But my grandmother, during her leukemia illness,
Mm.
was still at work, making sure, like, hey, I need my insurance. So I probably got that figured out fortitude
Yeah.
from them and that work ethic from them. But really, it was, I want to be here for my babies.
Yeah.
You know?
Yeah. Do you feel like, in a weird way, your baby bringing home that cold saved you?
Oh, yeah. Because think about it. I didn't have a lump, you know. Um, Other than that cough, I didn't have any other symptoms really. I mean, like the textural changes, it looked a little different, but when I showed it to my OBGYN, she wasn't concerned by those skin textural, and even the firmness of my breast. So, now I would say I probably should have, just ignored her, but of course, someone that you've been with for a long time, you think, oh, okay, they're experts in this. But now we know, that a lot of community doctors or OBGYNs or practitioners that are not in oncology, they're a lot of times they're not familiar with the statistics and those cautionary signs, and they actually need more training. So yeah, that cold definitely helped where it facilitated me being diagnosed.
Right. And can you explain to us, what does metastatic breast cancer look like? So I'll pose it this way. Did you have a double mastectomy?
I mean, there are some people, it's interesting because the standard of care pretty much leaves it open, right? Because some studies have shown that there is some benefit for removing the primary tumor, and some show that actually there is no added benefit of removing the primary tumor. So it really depends on your risk level, whether or not they choose to do a lumpectomy or mastectomy, and to remove lymph nodes. For me, I didn't have a mastectomy. They said that the pretty much the horse had already left the barn. There was not going to be any added benefit because usually they do a lumpectomy or mastectomy to remove the primary tumor so that it's pretty much buying you time so that it's not able to spread, because you don't die from breast cancer in the breast. You die from when it goes to other organs and wreaks havoc on other parts of the body. And so for me, it was chemotherapy right away.
From what?
Breast.
I know you said when you when you were receiving chemo and people were coming in and out, and that's sort of how Chrysalis was birthed. But when did you actually do it? Like, did you realize,
Mm.
okay, like, when was it like, okay, it has to be done? Like, it was
Yep,
birthed
yep.
in those moments, but
Yep, I saw how much of a help it was. My little checklist then became the Chrysalis Care Tracker, right? And so it not just once you assess the medical piece, but there's so much more beyond the medical piece. So once you determine, okay, am I getting standard of care based off of the national guidance that's applicable to me? Now everything else is to make sure that I stay on it and have the best possible outcome. So that's nutrition, that's integrative therapies, that's managing side effects, it's dealing with insurance, income, family, intimacy, exercise, all the things. So I found that it was really a benefit and a help to so many people, where they were making sure that they were fact checking their doctors, getting that complete diagnostic tools, signing up for clinical trials if they needed to, staying on track and getting the best outcomes possible. And so on my cancerversary, that's when I decided to call
wow.
it a thing. And so that's the reason why I called it the Chrysalis Initiative, because in that chrysalis, it's a transformation that you're going to go through, Cancer sucks. It's horrible. It's awful, but there's
Mhm.
still beauty in you being able to go through this transformation. It's almost like you get reintroduced to who you are,
Mhm.
right? You don't realize what you're capable of until you go through this. But also based off of providing that wraparound reinforcement for folks, meaning we're going to have that buffer around you as you go through this, and you're going to be okay.
Mhm.
Because, it's so much that are on us. So we consider ourselves like that concierge service, if you will.
Yeah.
Like we got this. You don't have to deal with all this on your own. And Black women, a lot of times, we're set out to do it by ourselves, and we're the most disrespected and the most overlooked, and the ones who they don't think about what we need, and that we need that additional care, right? It doesn't even come to some people's minds. And so we help them advocate for themselves. We connect them to resources that they might not have thought about on their own, and we help them realize that you don't have to muddle through. So meaning that, because a lot of times and this is another thing that's important for our health system partners to understand, you can have women that are not under the poverty line that are still struggling, right? And what they're going to do is they're going to maybe skip a few meals, or they're going to skip their medication, or they're going to skip that appointment, or they're not going to adhere to their treatment because of side effects or costs or whatever that barrier could be. And so it really is building that relationship so we can preemptively make sure that they don't fall through the cracks.
So the next question is, I'm a Black woman. I have breast cancer. Jamil, how do I get in contact with Chrysalis?
They text you.
That, but if they don't have my number,
Then they can go to the chrysalisinitiative.org, bcnavi.com, call us on our 1-800 number, 1-800-929-4979, email us at info@thechrysalisinitiative.org. So find us on social media, so we are there for them. And a lot of times they find us through their hospital because we're working with 170 hospitals now. 170.
that is amazing.
Mhm.
Now, my next question is, devil's advocate. I'm Hispanic. Am I still okay? Okay. Okay. Okay.
We find that white women experience bias too, whether if they're single or they live in a rural area or they're young or they're old, so bias shows up in a whole bunch of different ways. So equity benefits all races. So we work with all women.
Now, you said when you were first diagnosed, why God? Like you felt like he was stripping everything from you. Did you find the answer?
I'm still here. So I feel like I have this arrangement, this agreement with God, like, let me be here, raise my babies, and I will, show what's possible. I will show people what you can do, and I will help these women, that I can help, because 50,000 is a good number, but I always think about how
Things so fast. How many women
50,000
that you have helped?
that we're actively helping, yes, annually. But but think about all the people that don't connect to us. But it's also really encouraging that we're evidence-based, we're data-driven, we publish our results, and we do see that other health systems are taking note and doing it, right? And so I really think I would love to work myself out of a job, and it'll just be the standard, meaning a person gets diagnosed with cancer, they go to the doctor, they get the standard of care based off of the national guidance, right? No matter what income or insurance that's going on, they're connected to resources, meaning it's not just there at the hospital, but the legwork is done to make sure that they're connected to all those resources preemptively, and that there's an ongoing checkpoint on how these patients are doing, because things change, right? They might have had good income a while ago and they don't have it anymore. They could have had insurance that was good a while ago, but they don't have it. Or they're suffering from some side effects, or they're not being monitored appropriately, or they're dropping off as far as their maintenance therapy. We have to keep those ongoing relationships. And I understand that takes capacity, right? I understand that. But I think that if we have it where it's just the standard, all of our outcomes improve across the board. And it actually generates more revenue for health systems when you don't have all of these costs based off of them.
Right.
So I think the payers got to get involved too. The
Yeah.
government, the payers, let's just have this be part of standard of care instead of having a wealth care system,
Mm.
you know?
'Cause that's what it is.
Right. Hmm. But the thing is, even Black women with money, they actually showed that studies show that Black women with the higher incomes are the ones that experience the most bias in their care because of the implicit and explicit bias within health systems. Because there's a bit more accountability embedded in Medicaid and Medicare. So with the commercial insurance, that
The
these Black
onus is
women,
on you.
right. So we need that accountability, and we need it just built in as part of the standard. The same way that I get it in colleges at the health system,
Yeah.
have patient navigation built in, and not just the nurse navigator.
Yes.
Nurse navigators are important, but they're not pulling everything together. They're telling you about, okay, I'm
Your
going to connect you
appointment.
to the social worker. I'm going to onboard you and orient you with how our systems and processes work here. Um, but if you're not a priority to that social worker, then you're unbeknownst to you, there's so many resources that could benefit you that you're just not going to know about. So that connection piece has to happen. There has to also eliminate these silos within the health system so everyone has full visibility. And that's what we do. We kind
Yeah.
of force all these departments to work together because we have the coach who is kind of that connection point, and they report within BC Navi, which is the care tracker platform, how a patient is doing in all of
Mm.
those different categories I talked about. Unbeknownst to the patient, they don't know that they're vulnerable. So if
Wow.
they fall below baseline, it sends like a bat signal to the full team. So we preemptively make sure that that patient isn't going to fall through the cracks. And if it's a health system partner, we're flagging it for them too, to say, hey, this is what's going on. Because if you think about it, most health systems, even if they do have a patient navigation system within their health system, they're seeing 250 to 500 patients. And unless you're that squeaky wheel, you're going to be missed. But if you are connected to an organization like us, where each coach has maybe 50 at the most, right? And we are flagging for them, hey, this is what's going on. And we also provide that transparency and visibility for them about those bad actors, you know, within the cancer center.
Is you are going to change the game of not only oncology and cancer care, but health, emphasis
Mm.
on health care. Jamil.
It's interesting, we do get requests to like help with other diseases and things like that. And right now we're still only focused on breast cancer, ovarian cancer, and lung cancer. But I'm sure it would be effective in other diseases as well, but I think it just, it's not enough to just check off the box, because there's also a number of different equity initiatives that have been launched by various agencies and different organizations. And sometimes they're brought in for technical assistance based off of what we see, how it lands on the ground. And I tell them, some of my most racist doctors, their cancer centers would pass this test or this assessment. And so you really have to penetrate and think about, okay, what is the evidence as far as the accountability goes? You can't just check off the box. What about doing that deeper dive based off of their data, to see, okay, what's going on with their specific patients?
Right.
And that's the other piece that we do. Our health agency that provides a lot of our support is called Eversana. And they helped us develop the app, the platform, the algorithm, the equity assessment. They help us with our papers and publishing and research projects.
Amazing.
And so we find that their data can really illuminate for them where those issues lie. So, are they overall, as a health system, providing standard of care based off of the national guidance? And if they are, which patients are falling short of that? And what are the contributing factors? So, we also conduct focus groups with those patients, and they can really know, okay, this is the experience of this woman of color as she walks through the doors and where things are falling short. And it's really eye-opening a lot of times for them, because I think, the health systems just think, all right, well, we have it, right? We have these systems in place, we have these processes in place, but it's also how is it implemented? How is the experience of that particular patient? How are these women faring?
Right.
It's interesting because, most of our hospitals when we got started were in the greater Philadelphia area.
Mhm.
And it just ran the gamut. Some were really good on the
Yeah.
medical side. Some were horrible in the metastatic side. Some were really good with young women. Some were bad with triple negative. It was all over
Mhm.
the place,
Yeah, 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 yeah.
but at least they were able to take action
Mhm.
based off of those insights. And we see that the care gets better and better.
Life saver. And in the beginning, I normally ask my guests, who do they say they are? But we just had to jump right in it. But in all of this, who do you say that you are?
I believe I'm a mama bear who doesn't like bullies. And I'm one of those people that figures it out, you know? If I don't know about it, I'm going to figure it out. So I'm a learner. I think I'm a learner. I'm a mama bear that doesn't like bullies. And I'm a learner. And so I think, my great grandmother used to say, how you do one thing is how you do everything. And so that definitely applies to me. It's like, I'm resilient. Um, and so, yeah, I'm going to figure it out. I'm going to learn. I'm adaptable, I'm resilient, and I'm a mama bear. So I go hard for the people I love, but I'm also the person who's going to advocate because I don't like bullies. And that's been since I was little. Um, so I'm going to have people's backs when they need it.
I love that. And after everyone not only Googles Chrysalis Initiative and they
Yes.
listen to your words and they see your face, who will they say you are?
Mm. I think I'm different things to different people. I definitely do. And I think it also depends on if they know me or not. Because, of course, you can kind of appear a certain way to certain people, and they might just read your bio and think, okay, and they figure that that's what I'm about. But really, I think what motivates me the most is how can I be helpful in my family? So whatever I'm doing, my motivation, my biggest motivation, my fuel, is my family. I think like that pretty much puts the wind in my sails, and the air in the tires to do whatever I'm doing.
Everyone, now that you know that Jamil is going to win the Nobel Peace Prize, you understand why. Remember Chrysalis Initiative.
Yes.
Anyone dealing with breast cancer, she also said ovarian cancer, she also said lung cancer. You don't want to do it alone. Well, Imma say it one more time for the people that need to turn up the volume or Chrysalis Initiative. Jamil, thank you so much for pouring into our world because that's exactly what you're doing.
Hmm.
We
Thank
need you,
you.
and I'm not going to speak for why God put you through this because I don't know. But
Yeah.
I do know he had a plan and
Yeah.
has a plan, and in your work, you are saving millions of
Yes.
people.
Yes. Absolutely. I mean, the impact that we have, I'm really proud of.
Yeah.
And our coaches are very motivated. Our wraparound services team are really motivated. Our board is highly motivated. Everybody is just amazing. Even the doctors that we work with, we call them our equity champions. We are focused on doing what we need to do. And I really think that, based off of what's showing is effective, this should just be the norm,
Yeah.
right? Meaning, and I think maybe the White House, NIH, NCI, I think they're there. They're investing in patient navigation. That's the first step. But I think the accountability piece is the same thing. We need leaders like LBJ
Yeah.
when, due to redlining, and we found that, cancer care was not equitable. And they said, hey, if you want these Medicare dollars, then you have to integrate
Yeah.
and you have to provide care to these people, these patients of color. And, they didn't want to do it, but,
Yeah. They
you know,
wanted this.
right. So I think it's the same thing. We
Yeah.
can't have Jim Crow in healthcare. And that accountability has to be there. And I hate the hospitals I work with hate it when I say, well, what would you do if you had a doctor, right, that was just punching Black women in the face? They were just punch them in the face, like, would it matter then how much money that oncologist brings in? Would it matter, whether or not, if you can hold them accountable or not? Because that's the equivalent. If you have if you have an oncologist, and for whatever reason, whatever the system breakdown is, where this patient is not receiving a full and complete diagnostic, or if they're delayed in getting the testing that they're supposed to receive, or they're not receiving the standard of care, right? Not just what can they qualify for quickly, not what, is okay, well, we're just going to assume that she can't participate in that clinical trial because she's single or she doesn't have the support resources or because she's a Black woman, and whatever assumptions that you come up with. What is the standard of care where she could possibly have the best durable response? That's what we're going to provide her. And this is what you have to make sure that she adheres to, meaning you've cleared the runway of the barriers so
Right.
that she can adhere to the treatment that's going to work for her.
Right.
And we can figure it out. We can be that thought partner and provide those resources so that that pathway of, because this is an ongoing thing.
Yeah.
I know that some folks ring the bell and they're like, oh yeah, we're done. We're not done.
Yeah.
So even if you're not in active treatment, this is your life,
Yeah.
unfortunately.
Yeah.
And so it's now a part of everything that you do. And you're going to even see that it clears the pathway where some friends you thought were friends ain't going to be there no more. Some relationships you thought were going to last ain't going to last, right? But this is your life,
Yeah.
and you don't have to do it alone.
Jamil Rivers, Chrysalis Initiative, accountability, no Jim Crow, hashtag Chrysalis Initiative. You guys follow, send out the website support, donate everything because this is life saving. And you heard it on the Humanitarian Heartbeat podcast. Jamil Rivers, Chrysalis Initiative, Nobel Peace Prize. Thank you so much for joining us. We'll see you
Oh,
next
thank you for
episode.
having me. Appreciate you.
Of course, my love. Bye.
Bye bye.
On behalf of everyone here at the Humanitarian Heartbeat podcast, we thank you, the listeners. You could be doing anything else with your time, but you decided to spend time with us. And for that, we thank you. We feel so special. To our guests, thank you for taking the time out of your busy day to impart wisdom, information, and knowledge. What a blessing that is. To all of the listeners, please make sure to follow us on social media at the Humanitarian Heartbeat podcast. Of course, you can listen to us on your favorite platforms. Find us on YouTube and make sure that no matter what you do in this life, you follow your heart. God bless.